Welcome, everyone. Thank you for joining us. Take your time, have some water. Yes. So my name is Manelli Vasquez. I'm a licensed clinical social worker at the Weinberg Family Cerebral Palsy Center. I'm joined by my colleagues, psychiatrist Dr. Agnes Whitaker, rehabilitation medicine nurse practitioner Elizabeth Bates, and rehabilitation medicine doctor Hana Azizi. Today, the only person who's not here but was part of the treatment of this patient that we're going to present, and also part of the collaboration to this presentation, is Eduardo de Rosario. Dr. Azizi will be reviewing Eduardo de Rosario's slides that we have here. So our title of our presentation is Prioritizing Treatment, Chronic Pain, Mood Disorder, and ADHD in a Patient with Cerebral Palsy. Our team has no financial disclosures. However, Dr. Whitaker will be discussing off-label uses of olanzapine. The Weinberg Family Cerebral Palsy Center is dedicated to improving the lives of people with cerebral palsy of all ages through comprehensive medical care, basic and clinical research, and the education of medical professionals, patients, and caregivers. Our executive leadership is Dr. Carmel, our executive director, Dr. Hyman, our clinical director, and we have here our rehabilitation medicine director, Dr. Azizi. CP is a complex condition which requires integrated care, as we can see here highlighted in the slide, requiring surgery, rehabilitation medicine, medication, gross motor, fine motor, speech, feeding, and social emotional. Our center strives to provide lifespan care for the patient by providing neurosurgery, mental health, physical therapy, equipment support, primary care, physical rehabilitation medicine, orthopedics, and neurology. What makes our center unique is of 11 programs in the nation at the Weinberg Family CP Center is one of the few that offer the following specialties: mental health and psychiatry, genetics, adult transition care, and early detection. The agenda case study, we're going to review the educational and objective goals of today, the description of the treatment by each team, such as myself, Manelli, I'm going to overview the mental health, Dr. Whitaker is going to overview the psychiatry piece of the case, Elizabeth is going to review the rehabilitation medicine, and then Dr. Azizi is going to review the neurology part of the case and representing of Eduardo. At the end is going to be the best part, which is like why this is a community forum. The question and answer, the part where we all get to connect and talk, the part that I'm the most excited about. The educational goals and objectives for this is to describe the interaction between chronic pain, mood disorder, ADHD, and cerebral palsy in an adult patient. Identify the clinical and psychosocial turning points that contribute to the emotional and functional regression of a patient. Apply the strategies to support stabilization through individual, family therapy, and group therapy interventions. Incorporate vocational and community engagement as part of a comprehensive treatment plan, and demonstrate the role of interdisciplinary collaboration in managing a complex neurodevelopmental and psychiatric comorbidities. At this moment, I'm going to hand it off to my colleague, Dr. Agnes Whitaker.
Okay, thank you. It's a pleasure to be here. KM is a young adult man with spastic diplegia. He was a fraternal twin birth, born preterm at 31 weeks via emergency C-section, weighing just 2 pounds, 11 ounces. He had grade 4 intraventricular hemorrhage with periventricular leukomalacia and did not go home for 6 weeks. He was diagnosed with cerebral palsy by age 2. As a child, he was a happy-go-lucky social person who functioned well in school with a one-to-one para for physical safety and to help him with organization. He was diagnosed as having ADHD inattentive type, but had no behavioral issues. Overactivity per se was not a problem. In adolescence, however, he began isolating more. He was noted to be irritable. He developed repetitive hand washing and was diagnosed with and treated for obsessive compulsive disorder. In college, his freshman year was really his first time away from home. He wanted to major in theater, but early on experienced discrimination from a professor who did not want him in her class because he was wearing very loose clothes that she thought were inappropriate. He was wearing the loose clothes because these were the clothes that he could manage to get on by himself in his dorm room with the particular impairments that he had. Fortunately, there was very strong advocacy from the College Disabilities Office, and that was resolved. However, then the pandemic hit, and he spent his sophomore through senior year at home with his parents, who had been his caretakers and very involved with his ADLs up to the point that he left for college. And that all resumed when he went home during the pandemic. So you had parents who were very heavily involved with the daily routines of a young man who had just had a taste of independence. He completed his college degree remotely in 2021. After college, he continued to live with his parents, and he was very frustrated by being unable to find full-time employment. Voc rehab in his state was not helpful, and there were increasing family tensions. His parents, his father in particular, thought that he should be able to get a job. He began at the Weinberg in 2022 and was assisted by social work and our division with applications to government agency serving people with developmental disabilities. And for the first time in his life, he received home health aides for activities of daily living. He began to work part-time with a job that he got, working at minimum wage in theater retail, selling tickets. While he was on that job, a coworker accused him of staring at her, which was not the case. Our patient has some residual of strabismus, and he can sometimes give the appearance of staring, which is not the case. Again, this was dismissed as not being worthy of the complaint. And subsequently, his employer has asked him to be part of an advisory panel to improve theater accessibility. I want to say, although he won both of these, discriminatory actions taken against him, the experiences themselves were very traumatic for him. Recently, with the assistance of the Weinberger Center, he was accepted for SSI, SSD, Medicare, and Medicaid, which again also affords him some independence from his parents. He's receiving services through the Weinberg in 3 different areas: physical medicine and rehab, mental health, and neurology adult care coordination. So the next slide. Okay, it's hard sometimes to convey what multidisciplinary care might look like. So I came up with this slide view. If somebody has a better idea, I hope after the talk you'll pass it on. But I thought, why not present it as a table? Across the top are the different disciplines that are presently involved with his care, as well as outside providers. And down the side are roughly the years in which he's been involved with the Weinberg Center. Okay, so you can see that the first column is physical medicine and rehab. This was his entry into our multidisciplinary system. Okay.
All right. Hi, everyone. As Manelli introduced, my name is Elizabeth Bates. I'm a nurse practitioner in physical medicine and rehab in pediatric rehab at Columbia University Medical Center. I will be presenting the physical medicine and rehabilitation portion of our case on behalf of myself and Dr. Hannah Azizi. So just a brief rundown of his general function. On the gross motor function classification system, he functions as a level 2. As most of us know, this means that he is able to walk independently, but he does have some difficulty with uneven surfaces and balance. In terms of his manual ability, he is a level 2, so he handles most objects with reduced speed and quality. As Dr. Whitaker described in the overview, he is a left hemiplegic, so he has difficulty with his left upper extremity. In terms of communication, he's a level 1, he's an effective sender and receiver. And in terms of eating and drinking, he does have some limitations just with efficiency of eating, not with safety. In terms of therapies, as most of our adult patients, he did not have any recurrent therapies. He was getting intermittent physical therapy, and we did, over the years that we've seen him, we have recently gotten him into necessary services. And then just briefly in terms of his orthotics, he did have a previous use of a left posterior leaf spring orthosis, which he did not use consistently. And then he does use bilateral custom foot orthotics. So we will start in 2022 at his initial visit. He was 23 years old at the time. We assumed his care from a colleague. He had had prior Botox injections, 400 units to his left upper and left lower extremities. He did have improvement in muscle spasms and pain. The pain was most localized to his left upper extremity, and he felt that his walking was smoother after the injections. He had been started on baclofen, 20 milligrams 3 times a day, again with reported improvement in his dystonia of the left upper extremity. As Dr. Whitaker mentioned, he had recently graduated from college and had in fact started a full-time job, but he had noticed decreased endurance and stamina as a result of being more sedentary during his job. He also discussed with us that he was having some difficulty with this transition from college to entering the workforce. So our goals during this initial visit were obviously tone management and improving his pain and muscle spasms, which you'll see as a continued theme throughout the years that we've seen him. We also wanted to help him to maintain his independent gait pattern. And since he mentioned this to us, we wanted to help improve his endurance and stamina, as well as assist with this life transition. So our interventions included repeating Botox injections every 6 months, as this was the frequency that was most beneficial to him at the time. We decided to continue his baclofen at the dosage that he was currently on. And then we recommended a course of physical therapy to improve his overall endurance, as well as a home exercise program, including hamstring stretches. At this time, we also referred to the Weinberg Family Cerebral Palsy Center to get him connected with our mental health support and services to help with this transition into the real world. So 2023, we saw him again. Most notably, he just had some pain in the left calf that he had for about a week after his previous Botox injections. This felt like a spasm and muscle pain, which improved with a course of ibuprofen. And once the pain went away, he again reported effects of the toxin injections, most notably improved pain of the left upper extremity, as well as smoother gait pattern. Unfortunately, at this time, his full-time job had ended, and he had some plans to do some marketing work over the summer, and he did not end up completing the physical therapy course that we had discussed previously. Our goals remained the same. We did spend some more time encouraging physical activity, and we again provided physical and occupational therapy referrals. We decided to do occupational therapy at this time as well to help with that left upper extremity. As Dr. Whitaker again mentioned, he does have some difficulty with his activities of daily living, most notably with dressing and hygiene care. And he continued to work with our social work and psychiatry colleagues. So in 2024, just something notable was that we added posterior tibialis and extensor hallucis longus injections to help with his left foot position, and he was having some discomfort in the shoe due to his left big toe extension, so he reported good results from these injections. He had begun wearing custom foot orthotics that were from a podiatrist, and as I mentioned before, he had previously been prescribed a PLSO, but he did not find this helpful. He had continued to apply for administrative jobs within the theater industry, but was unfortunately continuing to have no success. Our goals again remained the same. We continued to discuss tone management, maintaining his function, and continued to focus on that left hand dexterity. He unfortunately was still not receiving any recurrent therapies, so we again provided referrals. We kept our tone management recommendations the same since he was having success, and he continued again with our social work and psychiatry. Now, most recently, we have started to make some progress. He has again reported increased range of motion after toxin injections to all the muscles that were injected. He has started receiving recurrent physical therapy, with his therapist also reporting improved range of motion. He had planned, the last time we saw him, he was planning to start occupational therapy twice a week as well, and he was motivated to increase the frequency of these therapies as he was seeing some success. And then, again, continuing to look for a job. So our goals, again, were similar, but we discussed a home exercise program, some exercises he could do at home to supplement his therapies. This is kind of the end of our portion, but just a couple things to note. Main themes for us are that he does suffer from chronic pain of that left upper extremity, as well as limitations with activities of daily living due to that left upper extremity impairment. And I'll pass it along to Manelli.
So I'm going to be reviewing the mental health piece in the case of KM. So KM was referred to me through Elizabeth Bates and Dr. Azizi, and KM wanted to initially just participate in our monthly support groups. And in our monthly support groups, we were talking about, in particular, like falls, because that is something that is very common, but falls in public transportation, because we're based out of New York City. So in that feeling of like the anxiety that you sometimes feel with transportation and then falls, and what if something happens with the elevator and you get stuck? KM then thought, these are things that I need to also process in regards to work, and the primary concern was really like employment and making sure that he was an employable profile. In that moment, my thought was, maybe that might not be the main thing. Maybe we should talk more about how you feel about yourself. But in prioritizing treatment, we need to make sure that we attend to like what he wants, and what he is telling me at that moment is his main thing that he wants to talk about, the anxiety that he has and the stress around employment. In our sessions, I did assess that he had no type of government or supplemental funded services, and he most definitely qualified them. For example, OPWDD, which are disability services across the state of New York, and he had no home health aid, no Social Security disability, or Medicaid. And that is something that we brought up in the sessions, and we talked about, hey, can you tell me a little bit about like what was your process in regards to getting access to any of these services? And I got to meet the parents, and the parents said, we've always asked, but everybody's always told us that he's fine, just focus on physical function and go to rehabilitation medicine. And nothing ever came of it. I then talked to them, no, you definitely do qualify. Let's go through this process around you doing it. Now, that being said, there was a lot of stress on the family because they had to help him out a lot as an adult at that point to gather all of his paperwork and to apply for all of these services. During our sessions, I not only noticed those pieces that he needed some more government funding and more support from our social services, is that he also had rapid speech. He also had a lot of irritability, and at a certain point, I noticed that his body was getting much more tense. He was having a hard time breathing, and I tried to do more of a mindfulness exercise, and particularly when we were talking about his traumatic incident in college. But what ended up happening is that he thought that I was doubting his experience instead of me wanting to help him emotionally regulate and process that feeling and be embodied in the traumatic moment, and then have a space here in the therapy session where he can be validated and express all the pain that he felt, that it's not on him, that this was a social barrier, this was a discrimination that happened against him. It was a tough session, but a really rewarding session, because it ended up being that he saw that I actually need to slow down. It took years to get him to slow down, but through repetition, he eventually did. At that point, I saw the irritability still happening, even though with me, he was able to slow down. So I decided perhaps it's a good idea to do psychiatric pharmacological evaluation. So I referred him to my colleague at that time, which was Dr. Jessica Dodge. And we also increased our sessions from weekly to twice a week, where we can do specific skills around interpersonal processing and how to resolve conflict and communication. And then afterwards, how does he feel about practicing his skills with his family and in community and job interviews? So the occupational progress that we saw with patient KM is that he was able to obtain a contract job and developed a consistent routine which helped his emotional regulation and mood stabilization. It reinforced our coping skills strategies that we did during sessions. And the interpersonal growth that we also saw is that when he was receiving feedback from work, instead of it seeing it something that is criticizing him, he saw it as an opportunity of professional growth and somebody investing in him and wanting him to improve. The emerging anxiety, however, around physical transportation started to come back. In 2023 in New York City, unfortunately, we had, I don't think this was like big news, but this was big news for us. There was a shooting around Times Square, which was where he interned, and he had to have a lockdown in the office until they made sure like the area was safe that he can actually commute home. Thankfully, his brother at the time was also near the area and was able to commute with him home. But that, as you can see, is like triggering his trauma that we talked about in a group therapy session and also in individual therapy sessions. So from there, we started to see, again, more tension, more anxiety. His contract job ended. He was not able to get another job at the same company that he really enjoyed working at. And that resulted in more family tension. That resulted in remorse in both sides around how they treated and talked to each other around ADLs and employment. Now, in 2024, when I saw all of this happen, I recommended family therapy, and we got them into family therapy. However, after about 4 months, it abruptly ended. The family, it caused them, they were getting stuck in family therapy, and it was hard for them to move through some of the conflict, and they abruptly ended it. And the way that they did it is that during the one session, they told the family therapist they no longer wanted to do that, and they terminated services. Unfortunately, at that point, things were getting worse with patient KM. He was having a lot of feelings of like, he is not worthy of living, like he doesn't even like himself. And he was expressing it explicitly to myself and the psychiatrist, Dr. Jessica Dodge, in 2024. And then as Dr. Whitaker was mentioning, he was accused of being socially inappropriate, which we all knew that has to do around his physical functioning. It has to do nothing like he was doing it intentionally. So what also was really traumatic for patient KM, like he finally found the support he always wanted and needed to address his mental health and his CP, and the main players in his support were leaving in his eyes. The long-term psychiatry was leaving our center, and then I was going on medical leave for an extended time for a surgery I needed to have. And that was devastating to KM, to the point we needed to get him more acute care, such as partial hospitalization. And for any of you who, I'm gonna describe a couple of mental health terms. So when you have to increase it out of individual therapy, it's either intensive outpatient program or partial hospitalization. First, you would go to intensive outpatient program because that's like almost every day, 3 to 4 hours, where you're doing therapy, and it can be virtual or it can be in person in a clinic. Partial hospitalization is exactly how it sounds. It's partially you're in the hospital doing intense psychotherapy and psychiatric treatment, and then you go back home. It's not that you're in the hospital, in the psychiatric unit the entire time. You're just there partially, and that is a more intensive level of care when things become more acutely suicidal. And just a quick plug, I'm not being paid by them, but they're actually really, really good, and they're almost all over the country. Charlie Health is a wonderful intensive outpatient program for any of your patients that are struggling for mental health, that takes Medicaid, that takes almost every insurance, and that is available. So if you can, plug that in as a resource. Now, going back to patient KM, what ended up happening, which was like beautifully, which is that when I was going out on medical leave, he was enrolled and accepted into Charlie Health, and he was going to be discharged from Charlie Health around the same time I was coming back from medical leave. And when I came back from medical leave, KM told me, I don't have a job. I was like, well, I figured you need to take care of yourself first before getting a job. He's like, but I don't have a job, but I feel better about myself. I like myself more. I was like, wonderful. So at this point in 2025, he's no longer acutely suicidal. There are still challenges that we're encountering. And as I look back at this case, like, he is able to slow down. He is able to incorporate mindfulness strategies. He's able to assess when he's having pain and how to ease the pain through breathing exercise or meditation. He now works part-time at a theater. He still has active interests in theater plans and applies to different disability organizations. 2 weeks ago, he was approved for every single service that he should have gotten as from childhood, and he's now participating in all of our support groups, and he's such a joy with like the people at our clinic and then also at the support groups. He's the one that encourages more of the patients now. At this point, I'm going to pass it off to our psychiatrist.
All right, so when I joined the Weinberg Cerebral Palsy, the program, I came from a background of working with patients with autism, but I am generally interested in developmental disabilities. And so this has been a very stimulating and intriguing experience for me, and I have a background in studying long-term outcomes of preterms. That's at an epidemiological public health. So I've been really so grateful now to be seeing the adults, children and adults, that I've studied primarily from a public health perspective. But let me move on. Which one? Okay. So I am going to be describing KM predominantly from a psychopharmacological perspective. When I have met with him, our sessions have primarily revolved around his history of response to psychotropic medications, what he's on now, any side effects, benefits that he perceives, and any emerging problems. So on entry into our service, the patient had been in treatment with the same psychiatrist in private practice since he was age 14, and his medications had remained unchanged. They were high-dose Prozac, up to 100 milligrams for treatment of obsessive-compulsive disorder, and stimulant medication, Adderall and then Vyvanse, 50 milligrams for ADHD. Now, you'll all remember that around this time there were some terrible shortages of Adderall, particularly in the state that we were in. So for that reason, he was switched to Vyvanse. He then, this is before I met him, he switched to a different psychiatrist, also in private practice, who was experienced in cerebral palsy, and who added Zyprexa to a maximum dose of 10 milligrams. Now, Zyprexa, that's the brand name, for a neuroleptic, which was originally used in schizophrenia, but has also been found to benefit other patients with irritability and agitation. And it is not, and this is just where I'll mention it, is not FDA approved for that purpose. The use of it for irritability and agitation really comes as an outgrowth of the use of neuroleptics like risperidone and Abilify in patients with autism. And in some patients with autism in whom those would be contraindicated or they've had bad reactions, clinicians will use off-label Zyprexa. So what particularly improved with the Zyprexa was the irritability, and with that, the family altercations got much less serious, and they were quite serious before that. In 2023, he began treatment with a Weinberg psychiatrist in parallel with the social worker, Manelli, and Vyvanse and Zyprexa were continued, but Prozac was tapered from 100 milligrams to 60 milligrams due to the improvement in his OCD symptoms. Our The psychiatrist worked with social work to maintain patient safety while the patient was suicidal, assisted with referrals to intensive outpatient, to Charlie Mental Health, and to a program for improving social engagement called Peers. While he was in Charlie Mental Health, the Vyvanse was discontinued. And in part, that was due to his report of a long history of sleep difficulties while he was on stimulants. These are a known side effect of stimulants. And the patient's perception that stimulants have contributed to his irritability and sadness, which is certainly also a known side effect of the stimulants, particularly in persons with histories of developmental disabilities, although they do have their uses. When I first met him, I felt that I was looking at a young man with a quite serious amotivational syndrome. At that point, he was going along with treatment and the efforts to mobilize him, but basically he didn't feel like doing anything much of the day. For those of you who encounter patients who have been on SSRIs for years and seem to have reached some kind of plateau and don't seem to be moving forward the way they want to with their own lives, consider this side effect of high-dose serotonin reuptake inhibitors. It's very often Prozac is a particular culprit. But I felt the Zyprexa was also contributing to weight gain, and he agreed also to taper that, and it went down from 10 milligrams to 2.5. He did actually begin to mobilize when he was off the Prozac slowly. I felt he was paying more attention to the work my colleague Manelli was doing. And the problem was that he began to report at the lower dose of Zyprexa increased irritability with his family and increased sadness and anxiety. So we started Lexapro, a different SSRI for anxiety and depression. That's now at 20 milligrams. And he is still on Zyprexa for irritability, now back at 7.5. I meet with him biweekly or weekly if needed to assess his response to medications and side effect and overall well-being. But even while his overall functioning and motivation have improved, the patient continues to complain of daytime sleepiness, and what really alarmed me, at one point falling asleep in the bathtub, which is, as you can imagine, very dangerous. He also reported fatigue and really expressed concern about his weight gain. So at that point, that seemed to be what we're really now addressing. He told me, he said, I think my psych meds are where they need to be. But he did need help with the sleep and fatigue. So at that point, I referred him to Eduardo Del Rosario of neurology.
Okay, hello everyone. I'm not going to be as cheerful and as Eduardo, but I'll try to present on his behalf and think what he thought when he made this presentation. So first, before that, I am so grateful that we have this service at Weinberg Family CP Center. Years ago, when our adults with CP, I could see that they have either depression or anxiety, and I told them maybe you should talk to someone, and then they asked where to go, and I didn't know what to tell them, because if you know, like even if I want to go and see a psychiatrist, it's almost impossible, because they just, it's out of pocket, they don't take insurances, and then it's very difficult and expensive. So I'm very glad that we have this service at Weinberg Family CP Center for our patients. So for Eduardo, when he saw the patient, basically, when he saw Manelli and Dr. Whitaker, he had told them that he has fatigue, which is common in adults with CP. And he mentioned that he's tired all the time, he does not have energy to get out of the house, and he's feeling bone tired. So what's important in this time to get a sleep history, relevant medical history related to that, and also to see how is his current function, in addition to what Elizabeth mentioned, which is like a CP classification, and also to do some exam in the clinic like strengths, ambulation, and also know that one clinic visit is not enough for that. So then he was referred basically to Eduardo, who is our transition clinic in Weinberg Family CP Center for evaluation of that. And he reported that he's sleepy during the day with frequent exhaustion. He sleeps 1 to 2 times a week for an hour or two between 10 a.m. and 3 p.m., so he takes naps. But concerns was he didn't have energy to read job postings online, and as Minelli said, going back to, again, focus on not having a job. And he thinks that difficulty finding a job is a significant contributor to his fatigue, which could be, that just makes sense. And also the goals for patients were improve energy without daytime sleepiness and obtain a full-time job, which is his long-term goal, like no, not long-term goal, his goal all the time. And his medical history, he has an annual visit with his primary care, not Columbia physician, but labs were normal except for some cholesterol and urinalysis. And then his weight is 170 pounds, which he increased from 140 before, and he has clearly had weight gain, and like I've told him also, we spoke with him. He was in-house, like, I don't know, like let's call it housebound, but basically during pandemic, he just stayed home. He couldn't go out from 2020 to 2021. He's on olanzapine, and also which could, like different side effects could be considered for that. And he denied any GI/GU issues, no like head issues, head injury, no seizure, no thyroid, which we know thyroid dysfunction could easily contribute to fatigue. No anemia as well could be a contributor, and cardiac and pulmonary issues, these especially are important. And then that's just so in night routine, basically, he's in bed at 10:30 p.m., out of bed 6:30 to 7 a.m., late nights, sometimes because of Broadway plays. He loves theater. Restful sleep, 6 to 7 hours a night, gives him better energy. And poor sleep is when he wakes up between 2 to 3 a.m., 3 times a week. Maybe sometimes he has to use the bathroom. And per parents, he snores at night. So in terms of his ADLs, now he has home health aide able to help him with some ADLs. He's a left hemiplegic, so the way that I also see it, he could function better, but also it has to have the motivation to do that. Mobility, he's walking all over New York City, he's using subway, he's doing home exercise program in the apartment complex, and he gets also PT and OT, as Elizabeth mentioned. So the differential diagnosis of fatigue in like overall, in adults, in our adults or adults with CP, depression and anxiety, which unfortunately is very common in adults with CP, which they are being managed by our mental health team at Weinberg Family CP Center. It could be metabolic dysfunction, which was ruled out, like thyroid dysfunction by his internist. Sleep disorder, also, he had a sleep study done, which was ruled out. He has some obstructive sleep apnea, but not not important much. So he had some weight gain, and also in terms of neuromuscular and MSK, it was discussed with him that he had, of course, some physical deconditioning during pandemic, and also aging could affect all of us with like basically losing muscle and getting weaker. And also a role of past severe medical event like prolonged hospitalization and orthopedic injuries. So his sleep study showed that basically so mild borderline obstructive sleep apnea overall, that's predicted apnea hypopnea index. I looked it up, I didn't know. So it was 9.5 event per hour, which is mild, and basically 3% rule. Overall, and the other one, the PAHI was normal. And only supine sleep was recorded. And basically, he does not have cardiovascular comorbidities. And basically, the conclusion was his excessive daytime sleepiness is not due to his borderline obstructive sleep apnea. And then the plan per sleep medicine team was, they discussed pathophysiology of OSA with him, and also like some potential treatments, including CPAP, oral appliance, ENT interventions, tirzepatide, which I think is used for weight loss as well, positional therapy, and advice to avoid supine position, and also to lose weight. So in terms of his weight gain, he has stress eating that started during pandemic, and in terms of medication, weight gain started before Zyprexa, and current BMI is 26.6. And the plan that Eduardo has for him is just to refer him again back to nutrition and endocrinology, and to consider maybe GLP-1s, but still consider the side effects, including potential gastroparesis, and also metformin, which has its own side effects. Again, his plan for basically his fatigue is that also rehab continues to, we continue to enhance his motor function and spasticity control. In terms of mental health, we continue to address his mood, anxiety, monitoring of sleep, medication management, and links to community participation. And neurology will start an individualized mobility and fatigue program for the patient. Also, his plan is to send to our PT in Weinberg Family CP Center, Dr. Lisa Yoon. Maybe he could benefit from gait analysis, but of course we should have goals before sending him there. And also continue with PT, OT, and adaptive sports. Actually, he came on a ski trip with us, not last year, the year before. He came on a ski trip with us, but that was just, of course, it was one day. Then long-term plan for weight management with nutrition. But I also wanted to say that, we are pediatric physiatrists, but we see quite a high percentage of adults. And as physicians, as medical providers, I have to say, we always look at them as a whole. I look at them and I say, you have seborrheic dermatitis, what shampoo do you use? Meanwhile that we address everything else, you have something so, and then we ask about, of course, the review of system, you ask all of them, and during exam, we also look, you have to do something for this part of your body or that part, or your weight, or your, I don't know, maybe, again, a toenail or something. So we see them as a whole. We do exam, we have a very thorough exam, even though but now Eduardo basically has this role of transition and sending them for different issues to different providers. If it's spine, if it's a knee, if it's a hip, if it's a tone management, he comes back to us. If it's mental health, which is very helpful. I think that was my part. Thank you.
So let's revisit the title of the presentation, Prioritizing Treatment, Chronic Pain, Mood Disorder, and ADHD in a Patient with Cerebral Palsy. When the patient entered the Weinberg Family Cerebral Palsy Center with the above 3 complaints, pain is addressed by physical rehabilitation medicine. Mood and anxiety and executive function is being addressed by mental health, and further evaluation in the adult CP clinic is addressing underlying mobility and fatigue issues. Now, in prioritizing treatment, we use 2 models, the medical model and the social model. So I wanted to provide the definition to the medical model and the social model, and how we used it as to prioritizing treatment for this patient. So the social model definition is this is one definition, not a problem of the person, but a problem of the surroundings, the barrier of society. The person with the disability is an expert in their experience. Now, the medical model views it as the problem of the person, something that needs to be cured, something that needs to be fixed. Now, this is not a bad thing, it's just a thing, it's just a fact of human existence. Sometimes we have things that do need to be fixed, sometimes we have to be treated. So how we used it is, for example, for his entitlement benefits, we looked at him and we said specifically, what are the aspects that you want some assistance in? And what do you want us to prioritize? And he would say, I want a job, I want independence. So then we would talk to him about, okay, this is some possibilities of how it could look like. And that's how the topic of OPWDD came up, Medicaid, and Social Security disability. So through that social model lens, but to get him to qualify for OPWDD, Medicaid, and Social Security disability, we had to apply the medical model lens, which is something that needs to be cured, something that needs to be fixed, and that needs his assistance. We had to go back and forth between those two models in order to prioritize treatment. So that's a way that they can coexist. Now, in the day-to-day clinical case that we were doing and the treatment that we have for the patient, physical rehabilitation medicine is able to address the pain and discomfort and dystonia and spasticity that the patient had that was relatively neglected for years, that impacted his ADLs and sense of well-being. I think last week we had our anxiety coping skills group, and he led the exercise around mindfulness and breathing, and he talked about the experience in his body around that. He is now able to detect that when he does this mindfulness breathing, his body relaxes and he does not feel the pain in his body that is associated to his anxiety. Now, other parts that I wanted to discuss with my colleagues here is that normal developmental separation and individuation is complicated by motor disabilities, and it is perpetuated by the dependence of others. So for example, he would have to rely on to his parents for, let's say, different ADLs, and therefore getting a home health aide to help teach him prepare a breakfast, to teach him how to wash the dishes and move things around, helped separate the roles of the parents instead of just being the primary caregiver and like sort of be a parent of an adult person with CP, and helped him sort of address, okay, these are my goals now and this is what I want to prioritize. Now, the past experience of college and workforce, that has been really traumatic for him, and I don't want to get into it too much because that's probably a whole nother presentation, but we always try to monitor and be careful about the emotional impact and help the patient navigate and name their feelings and know whether it's of the moment or what they're feeling. Now, family therapy, individual therapy, and group therapy has deepened the understanding of realistic goals of the patient and provided support and encouragement for him to become less isolated and less dependent on the family through socialization. I want to turn it back over to my colleague, Dr. Agnes Whitaker.
So from the psychiatric standpoint, it was apparent that his psychotropic medications needed a complete reevaluation, that it had been over a decade since, and he had been always on the same medications. And he was able to also reflect and report on the adverse effects of stimulants, which were started in childhood for ADHD. And so he has recently, we have discontinued those. The use of Zyprexa to treat irritability reflects an off-label use of this drug, but has a rationale in the use of this class of medications to address irritability in autism. Zyprexa is less likely than the two drugs approved for treatment of irritability in autism to cause dystonia, and so may be safer in patients with CP. Okay. Where did? Yeah. Yes.
All right. So just wrapping up the neurology and adult CP portion, as mentioned, his acute crises were mostly resolved, and he was in stable treatment plans as far as rehabilitation goes and mental health. So now the focus will be on treatment plans going forward to address his risk factors for chronic disease, including what was discussed with his sleep, weight gain, and poor eating habits, and in hopes of promoting future well-being that will also hopefully in turn affect his mental health and overall function.
Thank you, everyone. There's so much more we can say about this case, but we do want the opportunity to do question and answers. So that gives us the wonderful segue for any questions. Oh, yeah, thank you.
First of all, Heather Reardon from Kennedy Krieger. First of all, thank you so much for a really excellent session. Bring up a lot of ideas, and for the idea of co-management as well as collaboration that you're exemplifying at your institution. It's really inspiring to see that. I have one comment and then a couple of questions. My first comment is one of the things on the differential that I think we oftentimes forget about is periodic movement disorders of sleep. Now, in his case, that would have showed up later also on the sleep study, but even with a normal anemia, if you have a low or low normal ferritin, that can be associated with it. So it's readily treatable, and that's why it's important to screen. And the goal ferritin for children should be 50, so that's above our 30 or 28 that we normally see, and the goal ferritin for adults for people with either restless leg or periodic limb movement disorder should be 70. So easily treatable with some iron. In terms of my two questions, my first question is, with the fatigue, because I take care of a lot of adults with CP and deal with a lot of these challenges as well and try to figure out what the contributing and treatable factors are. Do you, especially with this history of ADHD, would you ever consider a short-acting, lower dose of a stimulant to try and help with the energy and also take away any burden that he may be having from some ADHD that's kind of subclinical? My second question is on perseveration in people with cerebral palsy. I see this very frequently. I think it's really hard for me to tease out the exact etiology because obviously OCD is part of it, but as you mentioned, executive function is part of it, but also there's a certain cognitive burden of always having to plan. Is this place going to be accessible? Am I going to be able to get this? What's going to happen? Is the one elevator that works down to the subway going to be working? As well as for some people, the vulnerability and uncertainty of having to rely on others. So like, what are we doing? What's going to happen with this? If, because they don't have control over where they're going or what's happening if they're relying on caregivers. And I think those all can play into it, and parsing out what the driving factor is, for me at least, can be challenging. So I'd be curious your thoughts on that.
I agree. In this patient, as he explains it to me, his OCD was predominantly around germophobia, which I think probably had some origins, at least, in his family and his concerns about cleanliness at all times. But that used to be very impairing, and he now tells me that he's largely outgrown that. Yeah. But I really appreciate the comments about movement abnormalities during sleep. That's very helpful.
I appreciate it too. Thank you, because then you're really bringing the element of how this is a community discussion by sharing those other pieces. In regards to the perseveration, that is something that I see in 90% of my cases. I'm working out a theory within the last couple of weeks where I think that there is an element of dissociation, because it is traumatic to walk around in this world to people constantly criticize and find something wrong with your body and that has to be fixed, and that you're constantly having to view it from that point of view. And at a certain point, the body and the mind does do a little bit of a disconnect. I'm still working out the theory and reviewing my cases and some clinical studies. So definitely reach out to me once I get it more to figure it out. But from the psychological element, I do think with the stress eating, I think that there is some sense of disassociation, especially because with his anger and irritability, he blacks out. Well, he used to, not anymore, thankfully. He would not be able to tell me what triggered it at all. I hope that helps.
Hi, this is Liz Barcuda, one of the child neurology and entity physicians at Boston Children's. You're right up my alley. I'm so excited. I feel like during the pandemic, child neurology entity folks were pulled into the ranks of having to deal with a lot of mood and behavioral challenges that were happening at that time, and I just feel like it has continued for a lot of them. I had to dive into the deep end on a lot of these medications. And so I really wanted to ask you your thoughts on many of the patients have number of neuropsychiatric comorbidities, ADHD, OCD, anxiety, depression. I mean, the list goes on. What are your thoughts on those side effects of Zyprexa versus the risperidone and Abilify are FDA approved, but there are newer atypical antipsychotics out there. The weight gain has been a big problem for many of my patients, trying to get GLP-1s approved and getting them there. And so I feel like I'm drowning, and sometimes I continue the stimulants because it has some protective on their weight. And I'm just, where do you use augmentative treatments for augmentative medications like buspirone, for the atypicals? I'm just curious kind of how you approach some of those more complex patients.
I love this question.
Well, it is very complicated, and I have found that at our institution, it seems to me that the go-to medication in peds neuro or adult neuro for irritability and agitation is quetiapine, which makes sense to me in terms of its having a low risk for akathisia, and not being a high D2 blocker. I think that the work in autism has sort of leaked into other developmental disabilities without a lot of critical overview. And I really worry about risperidone and Abilify. There's an evidence base specifically in autism and not in any other developmental disability. And both are, have high D2 occupancy, both have high rates of inducing akathisia and other EPS, and certainly in children with cerebral palsy, I would worry, many of them already have a baseline of white matter injury, and are they more likely to have dystonic reactions and other things? I think it would be a wonderful thing to have a multi-center study of side effects of these medications when they have been used in cerebral palsy, benefits and side effects. So that's I didn't choose Zyprexa. That was chosen by a psychiatrist on the outside who had previously had my job and was back in private practice. And I think he did very well with choosing that. Both the patient and the parents feels that this was the drug, the medication, that really changed things for them. And I suspect that had to do with it has some benefits for depression. Most even, in other psychiatric disorders, Zyprexa has a relatively smooth ride compared to other medications in that family.
No. Thank you. Thank you all. Thank you so much. Dr. Kim, I need a picture. Okay.